All right, we won't wait for the door to close. We'll go ahead and get started. So I'm going to introduce myself first. Thank you all for attending today. This very distinguished panel. I'm going to be the moderator of the panel. My name is Craig Beam, president of Beam & Associates. I've had over a 50-year career in healthcare, past chairman of the Heart Association, have worked with the people on this panel for decades, did a 4-year stint as an advisor at the NIH, have been on the board of the ABIM, and I'm currently the president of the American Heart Foundation. So I have been involved in healthcare policy and planning for a long period of time. So I'm going to start to my far left with Dr. Clyde Yancy.
Good morning. Clyde Yancy, Professor and Chief of Cardiology here in Chicago at Northwestern University Feinberg School of Medicine. Additionally, I bring the credentials to this format as a past president of the American Heart Association. Spent nearly 40 years as a cardiovascular investigator, teacher, and leader, and a long-standing volunteer for the American Heart Association.
Thank you. Jim Andrews, the token administrator on the panel today. So I am president and CEO of Deborah Heart and Lung Hospital, which is a specialty hospital in southern New Jersey. It's 94 licensed beds, only heart, vascular, and lung. It has the distinguished credential, which is the only adult hospital in the U.S. that doesn't balance bill or charge patients at all. We haven't billed a patient in 104 years. Prior to that, I was a service line administrator for a 12 hospital system, so I know big healthcare as well as small specialty healthcare. I know academic medicine. I was at Brigham and Women's Hospital for 9 years in their heart and vascular service line. So I'm adding a perspective of healthcare administration, service line development, efficiency operations to the panel.
Thanks, Jim. And to my right, Michelle.
Good morning, everyone. My name is Michelle Bowles, and I am the Executive Vice President for the American Heart Association that oversees the Global Quality Outcomes Research and Analytics team. So if you think about registries and certification programs, implementation science, and real-world evidence generation, that's what the team that I support and oversee at AHA. I have been with the American Heart Association for the last 36 years, last 20 spent in the quality and performance improvement areas with AHA. Thank you.
Thanks, Michelle. So really what the intention of this panel discussion is really to focus on is historically the AHA has really been science-focused and clinical outcomes-focused. And what we really tried to move is just from that as a silo into the triad of not just registries, quality improvement, performance enhancement, but also how do we improve workflows, how do we improve optimization of how we treat patients, and then finally the financial aspects of all this. So we have not really focused on the financial aspects of how these things not only assist in clinical outcomes, but in performance and patient experience. I'm going to start with Dr. Yancy, since he can tell the origin story. I was there too, but I'm older than he is. But really with the registry started over 28 years ago. So a little bit about how it started and what's progressed with it. Clyde.
Thanks, Craig. Well, good morning again. Question: why would anyone get up in the morning and come to a session entitled Accelerating Priorities Through Co-Designed Precision Quality Improvement? Really? But you're here, and I'm delighted to see you. Second question: why would the American Heart Association be at a Becker's review meeting? Becker's has a mission to promulgate best information, state-of-the-art practices to enhance your business performance. And we are a volunteer health organization that is science-driven. So is there some sync here that we're missing? There is. First, the American Heart Association brings into this equation a trusted voice, and that too is stated in the Becker's mission. Second, we have a relentless mission to improve the life and living of persons either at risk for or already experiencing heart disease and stroke. In each of your operations, cardiovascular disease, what we now think of as CKM, cardiovascular, kidney, and metabolic diseases, is your largest book of business. Third, we know how to do hard things, things that are seemingly impossible. What do I mean by that? In just the last 30 years, we've reduced the likelihood of death from a heart attack by 80%. We used to say 50%. Now it's by 80%. No other disease has experienced such a remarkable evolution in practice. Even better than that, the number of people having heart attacks now is at least 50% less, something that everyone thought was an immovable objective. We've moved it. Now, within the portfolio of things that we've done to make that happen, and this won't be a science conversation, even though a ton of science promotes what we've done, in that portfolio, in that suite of skills, has been a focus on quality improvement. You have probably heard this famous exhortation that emerged in 2003. It's even in the lay vernacular now. It takes 17 years to go from discovery to implementation. That's predicated on some very old clinical science, but it is recalcitrant. We are the only organization that's taken that to task, and we have effectively reduced that time for cardiovascular diseases from 17 years to 3. And that's just using analog technologies. Where we're now focused is using digital technologies to go from 3 years to less than 12 months. What's the driver? Well, 20 plus years ago, several of us, volunteers in the West Coast, volunteers in Texas, volunteers in the East Coast, really thought there was a better way. As clinician scientists, which I am, we do clinical trials. You pay for clinical trials, thank you. But we do these clinical trials to answer important questions, and when we have an answer, the next step is implementation. And there's a new field of implementation science, and it's still fledgling because we're trying to understand best practices. The best way to give you a sense of what implementation is, as a parent, you can provide the best information, but implementing it to your children and having them do the right thing, let me know what worked. So our implementation science was not quite as challenging, but it was hard. We had to find a way to take what was proven in our clinical practice guidelines and get it to the chairside and the bedside. And so again, 20 plus years ago, several of us thought somehow or another we needed to align with the guidelines, and we developed this vernacular, get with the guidelines. And so something as boring, as staid, as seemingly unexciting as quality improvement became our cause du jour. Taking these tenets that we discovered from clinical trials and bringing it forward into a variety of platforms. In heart failure alone, we have recruited 1.7 million patients in this country. We've penetrated over half the states in this country, and we've elevated the quality of care. But we've done the same thing in stroke, including groundbreaking discoveries that have improved not only the treatment of stroke, but the recovery from stroke. We've done the same thing for atrial fibrillation. We've done the same thing for coronary disease. All of these things that seemingly were impossible to manage, we've developed the technologies, we've developed the processes, we've developed the throughput. It hasn't required new science, but it's required new thought, new energy, and it's required process improvement. But that's how we've made a difference. And that's why we have the portfolio we have today.
Thank you, Clyde. So, Jim, I know Clyde's always hard to follow. So, Jim's an actual administrator who lives and breathes this on a daily. Not that Clyde doesn't see patients anymore. He's still an active clinician. But, Jim, you're responsible not just for the clinical outcomes, but also for the financial performance and the operations of a facility. So, maybe share your experience of using some of these tools and how you've implemented them.
Yeah, absolutely. And it's, I'll just reiterate, I'm part of a hospital that doesn't bill patients or send anyone into financial bankruptcy. That's my caveat before I start talking healthcare economics and some of the business of healthcare, because sometimes it can come off as a little sterile or uncaring, but it's talking about the business and breaking down the silos that occurs within an organization that I think allows us to start to make some three-dimensional decisions. Because when you have different parties, different perspectives in healthcare, all looking at a patient population or a disease state, they all come at it from their own unique perspective. And when it comes to managing heart failure patients specifically, as a service line leader, over a large system, I would run into CEOs that would tell me, of course I'm going to admit my heart failure patients. I make more money that way. And they probably did from a revenue perspective. But any time that patient went over 4 days length of stay, they started to lose money on margin. I would run into CMOs that would say, oh, well, of course, managing the heart failure patients and letting their private cardiologists manage them is the best way. We don't need to invest in infrastructure on the inpatient side to help streamline their care and make sure it went in accordance to get with the guidelines and all of the things that need to be done while someone's there with your patient, whether it's on the inpatient side or the outpatient side. And I've spoken with the CFOs that have said, you don't need to invest in abstract, or why are we doing this extra registry? An extra registry is just going to add more cost to the bottom line. And what are we getting out of it? They're just going to submit a report to a third-party agency, and maybe we get a shield or a star or a merit badge, and maybe we don't. And they stop progress from occurring. And my role as a CEO, I recognized the errors and the missteps that I was making as a service line administrator in trying to convince those parties around the value equation, especially when it comes to heart failure patients, and how to build a platform that truly optimizes not just the care for those patients, but also the financial outcome for a hospital. Because managing heart failure, if you're only looking at it from an inpatient perspective, is a negative feedback cycle. You have heart failure patients coming in, and you start to make the first mistake where you try to get them out too quickly, and then they're more prone and likely to come back as a readmission, or you keep them too long, and you start to lose money on them. And the most profitable way that you can look at managing heart failure patients is to keep them on the outpatient, right? You minimize the potential loss, the opportunity loss that occurs if there's a readmission and your penalties on your reimbursement. You minimize the loss on a longer length of stay when it comes to the margin that you're getting for that particular discharge, and you're trading it for a better care, and Dr. Yancy can speak to that, but also more efficient care, because you're not tying up your inpatient resources with a patient population that could avoid readmission altogether, and you're able to fill those beds, particularly if you're a small 94-bed hospital like myself, with higher margin, higher yield patients, sicker patients that require more complex care than your general heart failure patient population. And you start to avoid that negative feedback cycle, and you're starting to manage the patients where they should be managed, which is on the outpatient in accordance with get with the guidelines. You're able to keep them dry, keep them out of the hospital, and it's more profitable for everyone because you're getting incremental margin on those outpatient visits, on those titration clinic visits, as opposed to running a risk of them soaking up bed time resources on the inpatient side. But you're not able to really comprehend that or fully grasp that until you take a step back and you start to realize that the traditional data metrics that everyone has been utilizing, which is length of stay, readmission rate, your revenue per case, your volume, and you get away from that one-dimensional view and you start to look at the data three-dimensionally, right? You have the clinical quality element, you have the financial element, you have the operational element. And when you're able to have a tool that really combines all three of those, and you can see what the best path is, balancing the three elements that really come into factor in all of our healthcare lives. That's when you're able to start to pull things together and make the best decisions, not just for the organization, but also for the patient. And we're participating in a heart failure pilot with American Heart Association, leading into our tool, which is called Biome. And that's a tool that I've trusted for the last 10 years in my career. But that has been able to really synchronize everything and bring it all together where we are truly able to not just get with the guidelines, but manage to the guidelines. And that's been critically important for us.
Thanks, Jim. You know, in my practice, I would oftentimes go into large systems, and the variability was significant, and especially around heart failure patients. And we did use sort of the crude tools of average length of stay, and I always found it difficult putting together all those pieces of data in order to encourage them to get within one standard deviation amongst their hospitals and how they treated those patients. I know you've had multi-hospital experience too. What are your thoughts?
I mean, if you're able to solve for heart failure in one hospital, you're able to solve for heart failure in just one hospital. All the hospitals are different. Being in the 12-hospital system, the tools for success were different for the smaller local community hospital than they were for the larger academic medical center. The resources that they had at their avail were much different. Being in a specialty heart hospital now, it's a different solution than anything that I had in the 12 hospitals before. The key is triangulating the solution. So there's the quality piece of it, which is measurable. You use to get with the guideline information to manage quality, measure quality, to make sure that you're not doing something on the operational side, which is artificially inflating readmissions or patients coming back to the hospital or them needing to be unloaded more on the outpatient side. Yep.
So Craig, this issue of variability is important, and a lot of people have notebooks open, you're taking notes. Let me tell you three things that can help you adjust or address variability. The first is don't think about registries. Don't even think about quality improvement. Think about implementing systems of care. What's important about systems of care, it gives you the license to be multidisciplinary. The second thing, it requires a team approach, disease management teams, if you will. Everyone famously has these for structural heart disease in the cath lab. It works for every disease entity there is. So the first is address the systems of care, particularly if you have more than one facility, and let that be the template that everyone uses locally. You can iterate it as necessary, but have a backbone. The second thing is build disease management teams that are appropriately multidisciplinary. And the third thing, and this is the most important, if this is the secret weapon, I'm going to share it with you right now, find a champion. Doesn't have to be a physician champion, by the way, but find someone who wakes up thinking about it, who goes to bed thinking about it, and rushes to work the next day to think about it some more. Every time you have a champion, you have a disease management team, and you have a system of care endorsed by the topmost leadership, these strategies work.
We talk about measurement tools, and Clyde and I could spend an hour talking about this, but Dr. Yancy and Dr. Feinberg wrote a paper on readmission rates as a misnomer. What's the title of it? We're not going to talk about it, but I want to have you tell the title because it's worth the read, and it's readable for a non-clinician too. Clyde, what was the title of the paper?
Humbly, I'll tell you, I've written over 800 papers.
I know you have, so we can't remember all of them.
I can't remember every title. But most importantly, what we recognize, and this is something else that hospital systems need to appreciate, have the courage to challenge policies that are unproven. They may sound correct. Empirically, they may actually make sense, but you're using a phenomenon known as heuristic reasoning when you do that. And heuristics is not science, it's not evidence. And Dr. Feinberg and I became very vocal about the heuristic reasoning that implemented penalties for 30-day readmissions for heart failure when the underbelly demonstrated a significant increase in heart failure mortality. And it took constant advocacy to make that evident and to change the policy. So when a policy comes, have the courage to say, is this the correct thing to do for our patients? We shouldn't just become lemmings and follow a policy because it came from some dictate elsewhere. Challenge it in a reasonable way, have the conversation. And if the conversation doesn't make sense, collect your own information.
So you can Google it and find the article. This is the answer to the question. So I'm going to switch to Michelle. So Michelle really runs the consulting practice within the Heart Association. It reports up to her. And so we have some case studies of where we come into health systems and help them meld these three items, the process enhancement, the financial returns, marrying that with the registry and the science that we have. Michelle?
Thanks, Craig. So I kind of want to build on what Clyde was talking about with the three sort of, the secret sauce there with the system of care, the multidisciplinary team, and certainly the champion. And we know how critically important all three of those pieces, and they are three-legged stool. You need all of them to make a successful performance improvement, workflow changes. You need all of those pieces. And one of the things that AHA does really well, Clyde mentioned them. We've done it with, cardiac arrest, systems of care, STEMI, stroke, heart failure, moving into aortic stenosis now, and several other big areas of importance. It's really important to think about what AHA brings to the table. And again, it's a repeatable, successful model that has worked historically for almost 3 decades now. And rapid. And what's important about that is, I think Clyde said 3 years. We've been able to take something that 15, 17 years and do it in under 3. Imagine all the lives you're saving. Imagine all the quality of life, the quantity of life, and the cost savings. So it really becomes sort of the combination, the triad of the patient focus, the financial, being informed financially and fiscally appropriate care, as well as the scientific part of it. So that's kind of what AHA brings to the table. We have a team of over 200 quality improvement consultants and data folks that work together to do this. We're doing it in the US, we're doing it in 14 other countries as well, but we're really honing in and working. And a great example that I'll share is we recently we're working with HCA, and when you talk variability, you look across their hospitals and we brought together a cohort of sites and improved how they were treating patients that were discharged that were stroke with an unknown etiology. And the opportunity we saw there was so many of those patients were going home not knowing what caused the first stroke. And what's going to happen is they're going to come back in with a second, right? So that's the mission and the patient focus. But on the flip side, the business side is all those patients that went home that had an opportunity to go through a vascular workup, go to the EP lab, go through cardiology. We were able to see a 15% improvement in the patients in about 2 years through workflows, through eliminating variabilities, through looking at social determinants of health and access for those patients, that we found a whole, a bolus of patients that could then be fed back into the economy of HCA to receive better care, better workup, and have better outcomes. So that's one example.
Yeah, I know we're talking about CHF, which is obviously important. It's number 1 DRG in the country, but Heart Association isn't just CHF. Yeah. Can you tick off sort of what areas we're mostly working in now besides
sure.
CHF?
In the inpatient setting, we work, obviously heart failure, STEMI and STEMI care, coronary artery disease. We have an HCM program. We have CKM is the really big thing right now, and coordinated.
Tell them what CKM is.
Clyde said it earlier, but I'll say it again. Cardiovascular, kidney, metabolic health. There's no L in there for liver, but liver is part of that. So hepatologists are going to have to be part of that team as well. So we have a whole program around CKM care. We're doing an implementation science in about 150 sites around the nation. And so there's some great work in that space. Aortic stenosis, we just announced a big valve initiative as well. And on the outpatient side, hypertension control, certainly lipid management, the new dyslipidemia guidelines just came out, so we're doubling down on that as well.
Thanks, Michelle. So we're not just CHF. There's a lot of things, as you can see, we can assist systems with. Clyde, you had a thought?
There are 2 things that Michelle raised that I just want to emphasize, again, in the spirit of helping you with your note-taking. One of the things that we discovered by happenstance when we deployed a unique program, Implement HF, was that we created a data field. This was unique for a 7-region program, about 60,000 patients, that allowed something almost rudimentary to happen, documenting a patient's social needs. We were overwhelmed with the response. The subscription was immediate. 60% of the patients identified a very specific social need, the majority of which could be addressed. Now, we already know from data from the other AHA, the American Hospital Association, that 80% of most health outcomes are driven not by biology, not by physiology, not by the stuff that I study and create, but by the external factors that largely are centered in the social environment. Many fear access to the information because what happens if it's not actionable? But there's so many public service opportunities, public health opportunities, that by simply giving the patient the license to say, I need one of these aspects of the social construct, you change things. The second thing, we've mentioned it, Jim mentioned it, Michelle just mentioned it, but again, writing notes and thinking about the business imperative, it's not about hospital occupancy. My hospitals at Northwestern run at 99%. That's not hyperbole. We run at 99% occupancy. The real issue is not occupancy, it's bed capacity. And bed capacity is the number of beds times the days utilized. And when we can truncate the days utilized and increase bed capacity without more brick and mortar, that's your business imperative. So that's why quality improvement matters from a business standpoint.
I'll just add on the bed capacity front, because this is critically important as people go into the next 10 years of cardiovascular service lines and managing heart hospitals. There's going to be 20% more heart failure patients coming to hospitals over the course of the next 10 years as the baby boomers age into heart disease, as more people age into heart disease. This is going to be a resource crunch. And if you're not actively managing this patient population correctly on the outpatient side, forget doing cardiac surgeries or ablations or anything, you're not going to have the beds to get those people in because they're going to be entirely tied up with heart failure patients. So managing this patient population correctly isn't just the best thing for them, it's the best thing for your throughput for your heart hospital as we go forward.
So bringing it back to the pragmatics a little bit, Jim, looking at the tool that you're using, one of the things that impressed me the most is you can drill down to the individual practitioner's level. And, you know, I know CEOs and COOs generally don't like counseling physicians in how they practice medicine, but having the data, to speak to having the data around that, maybe assist a little bit in those discussions?
Yeah, I was taught pretty early in my career that administrators are better seen than not heard from when it comes to clinical matters. So I take that philosophy and I apply it to my life. Having a tool that allows you to take your abstracted data from being a static piece of information into a dynamic piece of performance enhancing information is crucial for this, because then you're giving that information to your physician champion or to your champion for heart failure and allowing them to have those challenging conversations, where as a administrator, as a CEO, it would have been really callous. It would have sounded like, oh, these people are costing me too much. I need you to get them out of the hospital. That doesn't make you feel good. That's not why I got into healthcare on the financial piece of it. But the conversation migrates now to how do we keep them dry? How do we keep them healthy? Because the secret to all of this is the heart failure patients, once they elevate to an emergency department or a hospital, are a negative margin driver for cardiovascular service line and for a hospital. They are more positive on the outpatient side, and you can then in return use those empty beds to do more high complex procedures. But having the conversation with a physician where you're saying, how can I optimize these clinical outcomes because it benefits my operational and financial outcomes, gets everyone working together, and it drives change, and it drives change at a fast rate.
So here is a not so subtle secret. Medicine is imperfect. Whereas Jim has some hesitancy about counseling physicians, I educate doctors at a local, national, and international level. It's my job to point out shortcomings. It's my job to elevate, to inform, to overcome the imperfectness that is so embedded in everything we do, including medicine. That's the beauty of quality improvement. It is anonymized, it is transparent. And once a group of physicians recognizes that performance has variability, or their top, as you would say, decile performers, and there are, I like leading and lagging performers, then the entire group changes. Mm-hmm. Our natural tendency is to perform at a bar that a leader sets. And when a leader sets that high performance bar, the others fall in line. But you have to have the courage to have that conversation, and you also have to have this. It's not a happenstance that Jim and I are sitting next to each other, because the dyad between the clinical leadership, the clinician scientists, the administrator, the financial operatives, that quadruped, if you will, needs to talk to each other. I mean, I'm getting text messages last night over dinner from my CFO. I should, because we have to be connected.
Yeah, and I think the advantage of the registry data too, again, I'll go back on my career, is I'd often start discussions. I would use the hospital's own data, and the physicians would be arguing with me over whether the data was correct or not.
Right.
And so you take a 30-year history of, I don't know how many data points we have now, but tens of thousands, if not more than that. And it's really hard to argue whether the data is accurate or not when you have that huge of a cohort as we look at these things. Michelle, you want to finish up?
Sure. By the way, when we have those conversations, it's the data's old, the data's wrong, or my patients are sicker than everyone else's, right? So that's generally what we used to hear. But when you put, again, 30 years worth of this proven track record in front of the data, and then we show it benchmarked against the rest of the country or a similar cohort, they start to have an aha moment of, okay, maybe this is right and this is accurate. The other part of that is, we're sort of an honest broker as an AHA. So when you're getting the data source from the American Heart Association, actually, I think there was just a study out in March from the Annenberg Foundation of number one, behind their personal family physician, the public trust the American Heart Association next. Right, so when you think about those, Jim, you said, the star or the widget or the little Olympic medal that says they're a gold hospital or what have you, the public trusts us, right? And so that goes a long way. But the data is so critical because it's so irrefutable that we're applying the science and then we're measuring in real world. It's not just clinical trial data, it's real world data. So what we use that for is to really say, one of the things Jim talked about is the biome tool. So under the AHA's advanced analytics, it's a product that we're working with Biome to come in and do the quality improvement, assess, and look at the way in which we can provide precision performance improvement that's custom for your facility, your system, what have you. Because it is, if you've seen one hospital, you've seen one hospital, but we know that there are things that are certainly can be adapted, or maybe you have to abandon something. So the opportunities are there for great changes and rapid changes and sustainable over time.
I feel kind of bad because the format doesn't really open us up for a Q&A time, but if anybody has some questions, we'll be hanging out somewhere.
At our booth, too?
We have a booth as well,
Yeah.
Downstairs. What's our tchotchke that we're handing out? Is it brains or is it hearts this year?
Hearts, and there you go.
So come get your free
Bags and hearts.
art at the heart booth. And any final thoughts from the panel?
You're the better closer out of the two.
Yeah.
No, I'm just pleased that everyone came in to participate. Just remember that the American Heart Association has 100 years of investment in trying to improve cardiovascular health and outcomes in this country, and we've done it. We've also created new knowledge. We've tackled difficult questions. But the other thing we bring to the table, all of you are embedded in systems that have early career physicians. They don't have to be academic physicians. They just have to be curious physicians. we can accommodate them. We can give them the training almost at no charge that will allow them to come back to your systems and be your new champions, your new facilitators. The partnerships are valuable because we understand how necessary it is in today's world to really implement quality. I don't need to tell you, your margins are tight. You have to have best outcomes almost every application. The way you have best outcomes is to have the most engaged physician group possible. We can help that make that happen. So,
And I would add, it's not just physicians. We do data workshops, so if you have business analysts who want
Yeah.
to learn how to work with the data, we had one here, or no, it was New Orleans in November, and I was surprised, there were over 100 people, business analysts from health systems that attended part
so
of
allow us to help you.
Yeah.
Thank you very much.
it. Jim, you have last thought? One more thought.
Oh,
We have 1 minute left.
I better make this a good one then, because that was really good ending. I'll simplify it. If you're an administrator talking to a CEO, if you're a CEO talking to your CFO, you can't manage the heart failure patients well clinically without a measurement tool like Get With The Guidelines. And you can't get to submitting that information without your abstractors. If you want to turn your abstractors into a revenue stream that creates opportunity for your organization, then you need to pair it with a performance improvement tool that's going to turn that information into something that's tangible and you be able to utilize it for your organization. And once you're able to do that, you're not getting with the guidelines, you're optimizing the guidelines and optimizing your organization. And that's when you can create value and really turn the corner on heart failure.
Thanks, Jim, and thanks to all the panelists. Thank you, everybody who's attended. You can come grab some of us here for a couple of minutes down below if you need to. So, or you can take the QR code and connect with us using the QR code too. Thanks.